hypertension, chronic leg ulcers, priapism, and stroke. Whereas on this other end, we have frequent severe pain crisis, acute chest syndrome, and osteonecrosis. Now, what I want you to again bear in mind is that for the hemolysis endothelial dysfunction, your important markers are your serum LDH, the reticulocyte count, plasma hemoglobin, and arginase, and then of course they produce these problems. On the other end, your hemoglobin level and hematocrit and blood osmolarity are the important markers. Bear in mind that if you have coexistent alpha thalassemia trait, it tends to push the spectrum to the right. The same tends to occur with high fetal hemoglobin. Although high fetal hemoglobin reduces a lot of the problems or complications, you may in fact end up with more problems of vaso-occlusion and osteonecrosis. Okay, now, so what are the important clinical problems that we see? In children, the most important problem, of course, is infection, bacterial infection, which is again driven mainly by splenic hypofunction. Okay, and then you of course have recurrent splenic sequestration. We tend to have ischemic stroke and dactylitis, which is the hand and foot syndrome. Among adults, you start to see end organ damage. And one of the most important problems, and I'll show one or two slides on that, is pulmonary hypertension. Of course, you have chronic renal problem and all the other problems. Then, of course, we have the shared, problems that you can see both in children and adults. Okay, just to quickly deal with the issue of pulmonary hypertension, I want you to bear in mind that this is becoming the most important prognostic factor or marker for early mortality among adult sickle cell patients. And you can see the survival of the patients if they have pulmonary hypertension and if they have normal pulmonary artery pressure. There's a really marked difference. And just to show you again that the serum LDH parallels your pulmonary hypertension prevalence very closely. Now, one of the indices that we use as a surrogate for pulmonary hypertension is the tricuspid regurgitant velocity, jet velocity. Okay, and the cutoff is 2.5 meters per second. Now, if you have normal TRV, you can see that your LDH tends to be on the lower side, and as it increases, it parallels the increase in TRV velocity. And low LDH and high LDH also parallel what we see in terms of survival with pulmonary hypertension. Therefore, for those who look after adult patients, pulmonary hypertension is one of the markers that you have to take into consideration. However, what do you do with them? We still do not know for sure the best way to treat patients, sickle cell patients with pulmonary hypertension. Sildenafil has been tried, but the results have not been very encouraging. There are studies going on whether chronic transfusion or hydroxyurea might be the way to go. Okay, now let's focus a little bit more on what are the other modifiers of sickle cell phenotype. As we've said, when you look at the inflammatory processes that are going on, you can appreciate that there are so many factors, so many cells, so many enzyme systems that are involved, and variations of polymorphisms in any of those systems might alter the phenotype. Therefore, you have the cells, your neutrophils and inflammation, you have your red cells, and hemoglobin F and alpha thalassemia indeed have been the most studied of the modifiers. And with the advent of genome-wide association studies, so many other enzymes and genes have been identified that may have some roles to play in the phenotype or phenotypic variation in sickle cell disease. Some of them have been reproduced, and I'm showing some of them here. Things like UGT1A, which gives you the Gilbert phenotype, has been recognized as causing increased bilirubin levels and cholestasis. In terms of osteonecrosis, the bone morphogenic protein and annexin and clotho have been implicated. Tissue growth factor has been implicated in leg ulceration, same in bacteremia and osteomyelitis, and a whole bunch of cytokines and additional molecules have been involved in non-hemorrhagic stroke. Okay, now in terms of therapy for sickle cell disease, what are the mainstay for now? Of course, transfusion is one, either episodic transfusion for severe anemia or aplastic crisis, acute sequestration crisis, or chronic transfusion, especially for the primary and secondary prevention of stroke, or during pregnancy, or chronic leg ulcers, etc. And of course, hydroxyurea, is now the licensed drug, for sickle cell disease, especially in adults. And with the baby hawk studies, we also know that it's effective in children. And primarily, it's a hemoglobin F inducer, although there are other properties of hydroxyurea that make it worthwhile in the therapy of sickle cell disease, as we shall see. And then, of course, we do symptomatic measures, pain management, hydration, and stem cell transplantation is obviously the only really curative treatment. So this is what we have now. There are so many other modalities in the pipeline, either for pain, for anti-inflammatory, or even F inducers. And because hemoglobin F is so important in modulating the phenotype of sickle cell disease, I think we need to have a good handle on what actually controls hemoglobin F levels in sickle cell patients. Okay. Now, hemoglobin F is also under genetic control or at different loci. One of the first that we recognized was the SMN1 site in the G gamma promoter region, which was the basis for the haplotyping, in sickle cell patients. We know that the SMN1, is carried on the Arab, India, and Senegal haplotypes, which are associated with the highest, hemoglobin F levels and the mildest, disease phenotype. However, now the BCL11A on chromosome 2 and HBS1LMYB, which are pro-oncogenes in the intergenital region of chromosome 6, are also been shown to be quite important, and these three together probably account for 150% of the variations in hemoglobin F levels in sickle cell patients. All those have implications for management of the disease and for our understanding of the pathophysiology. Now, so what other drugs are now being used for hemoglobin F induction? Apart from hydroxyurea, there are quite a number of other drugs. Some of them have been tried in the past, with varying results and varying toxicity. But so there are some others that are now, in the pipeline. But hydroxyurea is still the most favored. Now, hydroxyurea, of course, and it's also referred to as hydroxycarbamide or hydrea, the genetic name. It's ribonuclease reductase inhibitor, and it's been used, of course, for different myeloproliferative disorders. We know that it decreases the frequency of pain crisis, improves anemia, and decreases the frequency of acute chest syndrome, in sickle cell patients, and those are the main indications for its use. Okay, but it also has other properties apart from F induction that are also quite important. The red cells become more pliable, so that because there's increased water content, the MCV increases, so they can maneuver through the small vessels of the body. Okay, then the total white cell count, which are also very important, in terms of the endothelial interactions, are also reduced. Same with the reticulocyte count, and in particular, the hydroxyurea is also a nitric oxide donor. So for all these reasons, it's a really wonderful drug in sickle cell disease. And from the experience we've had so far, the side effects or adverse effects are tolerable. The fear that patients have and other doctors have, so that this might be teratogenic or promote malignancies. We don't really have evidence so far, relating hydroxyurea directly in a causal way to malignancies. And how does it really work? Just briefly, we know that your mature red cells are produced from your stem cell and progenitor cell through different cycling stages. Okay? However, there's a fast track where a few of the progenitor cells go straight from very mature to mature red cells. And it is this fast track, it is these red cells that result from that fast track that are the so-called F cells that have a higher level of fetal hemoglobin. So what hydroxyurea does is to inhibit the cycling. And because of that, there's a compensatory increase in the fast track. Therefore, you end up with a lot more red cells or the so-called F cells. So that's basically how it increases your total hemoglobin levels. However, the mechanisms of action in the other properties are still not quite well known. Okay, so that concludes that aspect of this of my talk. And then I want to briefly now go to talk about stroke in sickle cell disease. And this is probably the most devastating complication of sickle cell disease. And it is sickle cell disease is the most common cause of strokes in children. And there's a more like a 300-fold increase of rates in the sickle cell patients compared to normal individuals. And under the age of 20, about 11% of our sickle cell patients will have evidence of stroke, especially ischemic stroke. And we all know that overt stroke, the differentiation from transient ischemic attack is in terms of, the presentations and, whether you have imaging abnormalities, okay? And the silent infarct in particular is diagnosed in patients that are completely asymptomatic and just pick up the lesions on your MRI, of the brain. Okay, so we have the different types: ischemic, hemorrhagic, and silent infarcts. Okay, ischemic is mostly in children. Hemorrhagic is in the second decade of life usually. Silent infarcts is a problem of childhood. In many of the studies from the US, you don't see new silent infarcts above the age of 16. And of course, ischemic and hemorrhagic present with overt stroke, with all the well-known symptomatology. The thing with silent infarcts is that they don't have any symptoms, but it may be associated with learning difficulties. And that's why it is important to actually identify children with silent infarcts. And of course, your imaging studies, the thing to bear in mind is that your ischemic stroke affects your big vessels of the circle of Willis, okay? The distal, internal coronary, the middle cerebral, anterior cerebral are the most important vessels that are affected. The silent vessels are usually the deep white matter, okay? And in terms of screening, and I've talked a little bit about that, TCD, or transcranial Doppler, to measure the velocity of blood in the circle of Willis, is the method of predicting stroke of patients at risk for stroke, ischemic stroke. Whereas we don't really know how to screen for hemorrhagic stroke in adults, and these are usually because of aneurysms that rupture. Okay, and in terms of management, I'll talk a little bit about that. To prevent primary prevention and secondary prevention is by transfusions, and the same with acute management. Now, hemorrhagic stroke is more of a surgical problem. You need to involve your neurosurgeons. And silent infarcts, we still don't know, what to do with them. There's a current study going on of transfusion, to see whether regular transfusions will prevent new formation of silent infarcts. This just again shows the graphs, in terms of the ischemic stroke that is highest in early childhood and falls, and then the hemorrhagic stroke that is in the second decade of life. And this is a slide from Professor Lucas of King's College London, just to show you what happens in real life in terms of histopathological lesions in the brain. These are the arteries. Now this is the normal diameter, and then you can see arteries here with a lot of intimal hyperplasia with stenosis. Okay, and then you can actually see that although you may have a vessel that has intimal hyperplasia, there are also areas of medial degeneration. And it is those areas that tend to produce the hemorrhagic stroke. Okay. Now this is one of our patients, just to show you the bright objects that we see in silent infarcts, the deep gray matter. They may be single or multiple. Quite often they are they're single, but they may be multiple. And this is one of our own patients too, who had ischemic stroke at the age of 11 years. There was involvement of the frontoparietal lobes, and the MRA shows complete occlusion of the middle cerebral artery. Okay. Now, although we have an idea of some of the factors that may predispose to ischemic stroke, for a long time we were not sure of how to predict stroke until the late 1990s 90s, when Bob Adams, noticed that, if you measured the velocity of blood in the cerebral arteries, those with the highest velocities were those who were at risk for stroke. And with studying large numbers of patients, they could actually classify them that if you had, a velocity of more than 200 meters per second, you are very high risk. 170 to 200 is conditional, and less than 170 is normal. And, with that realization, that was the basis of the initial STOP trial to see if blood transfusion would prevent, stroke. And indeed, there was 92% reduction in symptomatic stroke risk in the patients that were transfused. So that was the basis for the recommendation that patients with high TCD should start regular transfusion. Well, the aim, of course, is to reduce the concentration of hemoglobin S to 30% or below. Now, the problem was, if you start that, for how long should you transfuse your patients? That nobody knew. And then that was the basis of the STOP-2 trial, and to see that if you stop transfusing patients after 30 months, would they be fine? Okay? And then so they had the randomized trial, and lo and behold, the patients who were in the non-transfusion arm started to have recurrent strokes, and the trial was stopped. Okay? Therefore, the thing is, patients should be transfused indefinitely. Then, of course, there were some, doctors who had noticed that their patients on hydroxyurea did well without needing, without having stroke. So it was thought that maybe if you could switch some patients from transfusions to hydroxyurea and see whether you could keep them from having strokes. So that was the basis of the switch trial, which of course again showed that patients, if who stopped transfusions and were put on hydroxyurea, there were incidents of stroke among them. So the recommendation now, of course, is that you transfuse these patients indefinitely, because once you start transfusing them, then they tend to have recurrences. Now, in France, some of these patients had stem cell transplantation, okay? And they found out that, and these patients were selected mainly because of previous stroke or because of abnormal TCD. And they had, a compatible related donor, so they had allogeneic stem cell transplantation, and they all did well, okay, without further, incidents of stroke. And that's, now we now think that, stem cell transplantation might, be a solution. But the problem with stem cell transplantation in sickle cell patients, first of all, is unavailability of donors, and then all the other problems associated with transplantation. And I know that we're going to have a talk about transplantation tomorrow, and I hope there will be some talk about what we do in sickle cell disease. Okay, now, first of all, there's unavailability of donors, and then results have not been very good, especially in adults, because of severe chronic GVHD. But recently, it's been found that a lot of the myeloablation or preparation that you do, you may not really have to completely knock out the bone marrow, because for sickle cell patients, if they achieve a balanced aneurysm, they tend to have, to sustain an acceptable level of hemoglobin. So that gives us hope that this may become more accessible to patients that need it with time. Okay, I'm almost at the end of my talk now. I just showed one or two slides just to tell you our experience in Kuwait. Kuwait is kind of unique to some extent because we have a fairly homogeneous sickle cell population that have the Arab India haplotype, and they have a very high prevalence of alpha thalassemia. Therefore, we have these patients who have these good factors. So how do they do? Do they still have problems or not? And that's what we've been studying over the years. So we now know that our patients have very high F levels. Usually the average is about 20–22%. They're usually asymptomatic in the first 3 to 4 years. We hardly ever see severe bacterial infections, and that's because up to the age of 16 years or more, most of them still have fairly good spleen function. We don't see stroke. Silent brain infarcts we see in only 3 to 5% of children. And we've done TCD, many of our patients, and it tests to be normal. We've looked for pulmonary hypertension in adults, and it's only in about 5% that show evidence of pulmonary hypertension, or like 30 to 40% that you see in other places. However, osteonecrosis is a big problem. You know, it's very prevalent. So our major problem with our patients is osteonecrosis. And this just shows the slide of the kind of hemoglobin F levels that we see in our patients, very high in the first 3 years of life, and then they settle at about 15 to 20%. And in terms of the complications, many of them still develop gallstones, and that's why we think the UGT1A phenotype or genotype may be responsible for that. So osteonecrosis is very common. Some of them have splenectomies because of recurrent sequestration. We do see few acute syndrome, but not as severe as in other places. And then stroke, paraplegism are very uncommon. So that's my last slide, and thank you very much for your attention.
Thank you very much for this presentation. Only 5 minutes late for our session. I think there is no time for questions. Shall we keep the questions for the coffee break? Okay. Or if there is time after the plenary session, we can take the questions for the two sessions. Thank you very much for the speakers. Thank you very much for the audience. And may I call the chairpersons of the session.
You brought everything outside. For the chairperson to present.
From Italy. He is a medical coordinator of Children to Cure in Italy, and he is a very good experience in the domain of bone transplantation in Thalassemia. Dr. Lawrence is going to present transplantation in the new Thalassemia era. Has bone marrow transplantation improved as much as chelation? How will it relate to gene samples? Please, Dr. Lawrence.
Thank you very much, Professor Bislawi and the organizer. It's a very big honor for me to be present here on the 8th of May, the Thalassemia Day, in such an important meeting on thalassemia. I put myself in a very difficult spot because this is I think it's things that many people in the thalassemia world wonder about, especially now that, as explained by the previous speakers, and as most of you know very well, that thalassemia has really changed. So the outlook of children with thalassemia now is very different from 30 years ago. So the point is, what is the relationship now of thalassemia in the new thalassemia area and bone marrow transplantation and even gene therapy? So I'm just going to try to make some comparison and maybe see what is the potential, what are the potential prospects. So first of all, yes, I'm a pediatric hematologist oncologist, and I am the medical coordinator of the Children Foundation, which is an Italian NGO developed by a group of parents that lost a child to cancer. So the objective of the Children Foundation is to increase access to cure for all children with blood disorders and cancer directly in low and middle income countries. So I'll try to make a comparison focusing mostly on what is my expertise, which is bone marrow transplantation. So I'm not definitely an expert of supportive care of gene therapy, so please feel free to interrupt. I'll try to be as quick as possible because we're running a little over time. So first of all, we've heard that long life supportive care for thalassemia has improved a lot. There might be some open issues, even though drugs are quite tolerable. There's still going to be potentially a problem with tolerance and also with tolerance to transfusion. So osteoporosis and pain is something that probably still needs to be addressed. In other words, chelation can take care of iron overload, but we probably not. We don't have a good answer yet for chronic marrow hyperfunction, osteoporosis, and pain, which can affect quality of life in all the thalassemias. Bloodborne infection potentially is a problem, even hepatitis C, and quality of life, even though it has much improved, and costs. You know that supportive care now for thalassemics, especially with the long life expectancy, is potentially extremely expensive. Bone marrow transplantation, very quickly, I'm just summarizing, you know that bone marrow transplantation for thalassemia has been done since the early 1980s. The first was done in Seattle, and then the Professor Lucarelli in Italy took over and did a lot of transplantations. Today there are probably more than 3,000 children with thalassemia that has been, children and adults with thalassemia that have been transplanted. The classical risk factors for transplantation for thalassemia that discriminated relatively well a low-risk group from a high-risk group, a low-risk group with a expectancy of thalassemia-free in the range of 90%, and a higher-risk group is basically the chelation history, and again, this is based on all data. Chelation history, increased liver size, and liver fibrosis. So if you had none of these risk factors, you're expected to do quite well if you were a child. Now, for adults, historically, the results have been pretty poor. So you were not expected, for an adult, you were expected to have even up to a 30–40% mortality rate from transplantation. But again, this was in the old era. I think now we are so good, as previously explained, to remove iron storage from organs that actually we could downstage many of these patients. So aggressive chelation could also be used to improve the risk for transplant. So you could use aggressive chelation to improve transplant outcome. This is a comparison of low-risk children with thalassemia, less than 5-year-old, normal liver, match-related bone marrow transplant, transplanted with low-dose Tardiva, busulfan, and cyclophosphamide. And actually, this is a comparison between the results in Italy and the results in Pakistan. Exact same protocol, same patient group. So 27 patients at the Military Institute of Hematology, Professor Lucarelli's group, and 20 patients in a small network in Pakistan. So essentially the patients were matched for gender, age. The only major difference was median follow-up. The reason is that it took much longer, as you can imagine, to recruit young children with a matched sibling in Italy than in Pakistan, where thalassemia is much more frequent. So the years it took like 6 years in Italy, while in Pakistan it took probably less than 2 years to recruit the same number of patients. So here you see the comparison. Essentially, there is no difference. So you can do very well with low-risk patients with a matched sibling, which unfortunately are a minority, even in low-resource settings, both in terms of thalassemia-free survival and overall survival. 3 patients died at EME, mostly for acute graft-versus-host disease. 2 patients died in Pakistan, mostly for sepsis. In Pakistan, we have seen much less graft-versus-host disease. We've seen no chronic graft-versus-host disease. Possible explanation is that there is a lot of intermarriage, so even minor histocompatibility antigens may be more matched compared to patients from other cultures. We also then extended this small network to India, in Jaipur, capital of Rajasthan. They had a lot of thalassemia, no transplant center. And actually, here we compared, actually we analyzed just the first 6 patients that were transplanted in startup centers, one in a government hospital in Islamabad, Pakistan, and the other one in Jaipur, and which you would assume that the first 6 patients represent the steepest phase of the learning curve, so those more at risk for not properly trained physician, not properly trained or not a well-organized supply chain. So, but actually they did very well. So the point is that within a strong cooperation program, so we will collaborate with them daily, do rounds either locally if possible or through Skype, you can have very good results from the very beginning. For high-risk patients, the thing is different. So I just want to stress that this is true for low-risk patients. So young children, no large liver with a matched sibling. Late effects, actually the most important late effect now of transplantation for thalassemia is really infertility. So delayed puberty, we know in females, if you have ovarian failure, if you have infertility, you also have endocrine failure normally. And impaired growth and development, second malignancies, and intellectual impairment has not been an issue with transplantation for thalassemia because we don't use any central nervous system directed therapy or total body radiation. Additional concerns, just because you live in a low resource setting, should be worried more about infectious disease, which normally do not occur in the standard Western literature. Actually, there's no evidence that this is the case. In Pakistan, we had 2 children with tuberculosis. The local doctors know how to recognize this and treat it. I don't know how to recognize and treat it. So actually, both children did well. We had a child that came from Albania. He had a very strange parasitic infection we didn't recognize. He had a matched sibling, he died from that infection. So actually, I think it's the opposite. I think children, as much as possible, should be transplanted in their own country by their own doctors. This is one of the reasons why. This is a very important information. This was recently presented at the European bone marrow transplant meeting that was in London last March. And it's a review of quality of life after bone marrow transplantation in patients with thalassemia from the Italian experience. So it was 109 ex-thalassemia patients transplanted in the 1990s and 80s and 90s. At the time of interview, the median age was 34 years, and the median age at BMT was 12 years. Oral busulfan cyclophosphamide, which is the standard, was used as a condition. Second malignancies occurred in 4 patients, 3.6%. I'm not sure that this is significantly superior to what you would normally expect as a baseline. 74% had either resumed or completed their studies, and actually the results were comparable to the healthy population. 77% had an employment and actually compared favorably to their age-matched population. 45% had a spouse or a partner, and 23 gave birth to 23 healthy babies. You know that even if you're exposed to chemotherapy, if you have a baby normally, it doesn't carry any genetic abnormalities. And the resulting birth rate, 4.7%, was only slightly lower than 7.9% registered in Sardinia in 2011. So we know that busulfan can cause fertility problem, but actually they may be less important than we think. So bone marrow transplantation not necessarily will make you sterile. Physical functioning scales show good scores compared to those obtained from sex, age, matched health population. Now this was only published in an abstract form, so hopefully it will be a... so the conclusion is that the next thalassemia patient will return to normal life after bone marrow transplantation, at least most of them. Cost issue. This, I'm referring to the experience in Pakistan. For low-risk bone marrow transplantation, the average expense was $11,000, which actually is comparable to very few years of supportive care. Compatibility testing is now much more simple. We can do it with a simple buccal swab that can be sent through regular airmail anywhere in the world. So we're able now to do HLA typing globally. So now we're doing for sickle cell disease children in sub-Saharan Africa. So you can actually easily know if a thalassemia child or a sickle cell child has a compatible sibling, and it doesn't cost more than $50 per child. Indirect positive effect of bone marrow transplantation, increased awareness about thalassemia, attracts family for screening. I will have another speak tomorrow on screening, so I will go into detail on this. It generates resources for supportive care and prevention. This is what happened both in Pakistan and India. Local government took over and actually funded the transplant unit and the preventive program that came with it. Increased compliance with chelation and safe blood use. Attracts and motivates professionals, empowers medical scientists to pave the way for the cure of related disorders, leukemia, thalassemia, and fosters research, higher education, and development. So it does contribute to the strengthening of the tertiary health sector. So I mentioned it before, I think the prospects now are essentially two, I think the most important. The first one is to use the advances in chelation to decrease transplant risk. So maybe to open up a definitive cure for those patients that have the appropriate indication, which is sometimes difficult to identify, also for higher risk patients. So right now you can actually improve splenomegaly with either hydroxyurea, you can decrease iron overloads in the liver and the heart by aggressive chelation. So those patients, once appropriately downstage, could actually do well with transplantation. The other important new thing is that there is more and more evidence that for the majority of children that don't have a compatible sibling, you can probably use one of the parents, normally the mother, as a stem cell donor. So there is increasing evidence that this is feasible and obviously is also much less costly than other alternative forms of transplantation, like unrelated donors or plasma. And actually, this is a small experience on sickle cell disease. It's actually in adults, in which they have used haploidentical, that is to say semi-compatible, typically mother or father for a child, bone marrow, and with a relatively reduced intensity conditioning, and actually on 14 patients they saw no mortality, no GVH. However, graft failure is still a big issue. But I think the most important thing for chronic diseases like thalassemia or sickle cell disease is not to have mortality or morbidity. Gene therapy. Now, I'm not an expert of gene therapy, so I will just summarize for you what I heard at the recent meeting. So you may know that so far, at least published, and this is a nice review on an open access publication, which is the American Society of Hematology Educational Program 2012. There are 2 patients done, one in 2007 and one in 2012. So the only available really is this one. Essentially, it's an 18-year-old with E-beta-0 severe thalassemia intermediate. So it's not, E-beta-0 is a very, very variable phenotype. And this is probably really a severe thalassemia intermediate, not a thalassemia major. But actually, he did show beta-globin vector-bearing cells 6 months after autologous transplantation with gene-modified cells, and achieved a stable hemoglobin in the 8.5 to 9 gram level. So engraftment of gene-modified autologous stems, however, needs administration of myeloablative therapy. So you cannot give the gene-modified cells as such. You have to clear the bone marrow. And so he also received busulfan. So at the end of the day, you may also have fertility problems as gene therapy is done currently. And so here I tried to do a very gross comparison, but I think it's a useful, let's say, intellectual exercise to compare long-term supportive care, bone marrow transplant, and gene therapy. So efficacy of long-term supportive care is probably more than 95%. So it's very effective. Life expectancy, I would say, maybe with supportive care now is probably close to normal. Theoretically, a thalassemia patient could survive, could have a close to normal life expectancy. Quality of life is variable, it's sort of a subjective, but you still have to have treatment and transfusion for the rest of the life. So I would say that is not optimal. Applicability in high-income countries is 100%. It's a very expensive. In low and middle-income countries, very variable, depending on what system you can rely on your family income. So this is, but most patients now don't, in low and middle income countries, don't have access to the kind of long-term care that will guarantee the proper life expectancy of quality of life. And it's very expensive. Bone marrow transplantation, if in the selected group of patients, you can have 90% success. Life expectancy after bone marrow transplantation, again, we have no reason to believe that it's not close to normal or normal. Quality of life is probably improved after bone marrow transplantation, but again, there's no reason. It's very hard to study this prospectively. But BMT patients essentially go back to a normal quality of life, most of them, even though fertility might be an issue. Applicability in high-income country for the indications that are clear-cut for bone marrow transplantation, that is to say young children with a compatible sibling, probably 10%, because both there are very few new children that are born with thalassemia in high-income countries, and because average family size is smaller. But in low and middle income countries, probably it's at least 30%, both because the majority of thalassemia patients are very young, and because family size is larger. So in Pakistan, roughly 40% of the children have a compatible sibling. Cost is actually less than supportive care. If you compare supportive care for 20, 30 years, bone marrow transplant is probably less than a tenth of the cost. Gene therapy efficacy, honestly, we don't know. There's only one evaluable patient, really. Life expectancy, potentially close to normal also. Quality of life also potentially could be quite good after gene therapy. Applicability in high-resource country, we don't know. In low and middle-income country, even less. We really don't know how gene therapy could be applied in low-resource settings. And cost, you know that a gene vector for that particular patient, every patient has to have his own stem cell transfected to the gene, so it costs $1 million. And actually, if you think about it, it's roughly the same cost of supportive care for 60 years. So it's also very expensive. So in conclusion, lifelong supportive care versus bone marrow transplantation. They're impossible to compare side by side. So to do this, you would need such a long follow-up, the results of which will become irrelevant by the time the study is finished. So you cannot have 20, 30 years of follow-up. 20, 30 years ago, we didn't have oral curators, so the data would be irrelevant. Bone marrow transplantation should be considered for children less than 7 with a sibling. 90% cure will return to normal life. Fertility possibly less than supportive care, but we don't know. Can be highly cost-effective, as I show you, and has the potential to be more widely applicable, especially in low and middle-income countries. Gene therapy, no firm conclusion at present, but positive proof of principle. Fertility could also be an issue of gene therapy. So I'll finish here, and I thank you very much.
Thank you very much for this very interesting presentation on stem cell transplantation. And now we have Professor Dr. Alaa Haddad, Dr. Alaa Haddad, the pioneer in bone marrow transplantation and pediatrics in Egypt for thalassemia and other malignant diseases. He is an initiator for bone marrow transplantation in Nasser Institute, and as well in Abu Rish Hospital, in our hospital. And Dr. Alaa is the dean now of the National Cancer Institute in Egypt. Dr. Alaa is going to give update in stem cell transplantation in thalassemia, the Egyptian experience.
Good afternoon, everybody. Thank you very much, Professor Kanal, for your invitation. I would like to share with you today our updated experience regarding stem cell transplantation for beta thalassemia major. Again, as everybody knows, stem cell transplantation is becoming an established treatment modality for many hematological, benign, and malignant diseases. Again, this line requires tremendous resources. It's becoming really difficult for transplanters in a developing country like Egypt to close the gap between what is possible and what is becoming available. As Professor Amal just said, we started our stem cell transplantation program at Nasser Institute in 1997. We're having 20 laminar airflow cabins, having the potential to do around 150 transplants per year. Again, we are one of 3 centers that are reporting to the CIBMTR in Cairo. And this is the total number of transplants that have been done over the past 15 years. We did more than 2,500 transplants and around 1,800 allo transplants. Again, as you could see here, beta thalassemia major represents like 10% of the total number of allogeneic transplants done at Nasser Institute, and this would include adults and pediatrics. But when we see it in relation to the pediatric age, beta thalassemia major comes to the 3rd indication for allo transplant in the pediatric age, constituting like 20% of the total number of allo transplants done. Again, there are some kind of peculiar issues that are related, especially to beta thalassemia major. One of them, donor issues, the motivation, donor motivation, which is one important thing that we used to suffer earlier. We used to find difficulties convincing families to that their healthy children donate their marrow to their deceased children, and peripheral blood stem cell collection facilitated things for us dramatically, especially over the past 10 years or so. Again, when you're facing a situation where you don't have a matched sibling donor, then we don't have anything to offer for patients with thalassemia. Again, some kind of peculiar toxicities like hepatitis, which is endemic in Egypt. And as I just said, the use of peripheral blood stem cell for allografting was initially overlooked for 2 major reasons. First, it contains at least 1 log higher content of T lymphocytes. Again, there were potential risks to healthy donors from the GCSF mobilization and the apheresis procedure. However, peripheral blood stem cell transplantation has been coupled with a faster hematopoietic recovery, more rapid and complete immune reconstitution, a similar incidence of acute GVHD to that reported among marrow recipients. There were no serious short-term complications among healthy donors. Again, there is a definite reduction in the risk of graft failure, which is quite important in the setup of beta thalassemia. And lastly, as I just said, a better donor motivation. But peripheral blood stem cell transplantation has been definitely coupled with an increased incidence in overall and extensive chronic graft versus host disease. As you could see in one of our publications, we concluded that peripheral blood stem cell transplantation was coupled with a faster hematopoietic recovery and a similar incidence of acute GVHD that did not exceed that seen with bone marrow transplant patients. And as I said, because of the risk of running into chronic GVHD. In Egypt, only 40% of patients could have an HLA identical sibling, and we do not have any representation. Actually, less than 3% of the donor list in the international registry are coming from Oriental origin, and that would make it quite difficult to find a match for our patients in the registry. And this might indicate how urgent it is to set up a donor registry here in this region, again to start our national cord blood bank. And when we talk about hepatitis and the situation here in Egypt, there is an overall prevalence of antibodies to HCV in the general population of around 15%. Again, patients who are PCR positive for RNA are around 10% of the general population, and hepatitis B surface antigen carrier rate is around 3%. And this would complicate things even more, where the decision to proceed for transplantation must be balanced between the absolute risk from death from veno-occlusive disease against the risk from the underlying disease. And again, in another publication, we concluded that hepatic graft-versus-host disease is a common complication after bone marrow transplant, and it's an important cause of liver-related mortality, and the high prevalence rate of HCV and HBV among our patients may have contributed to the outcome of hepatic GVHD and veno-occlusive disease. Therefore, an antiviral therapy should be considered early to prevent progression of liver disease and the setup of transplant. When we talk about thalassemia, it's the most common inherited single gene disorder in the world, and with a better blood transfusion and better chelation, what would transform it from a fatal disease to a chronic disease with prolonged survival. And bone marrow transplant, as just said, is still the only curative line of treatment up to now for such a disease. Again, in Egypt, and according to Professor Nani Bishlawi, it's the most common chronic hemolytic anemia with a carrier rate of around 10 to 10%. What I'm going to share with you our results over the past 15 years, and we included the patients under the age of 24 who are having an HLA identical sibling donor and in a good performance status. And as you could see here, our mean age was around 6, and the range between 7 months and 23 years. 94 males and 59 females were included. Again, according to Lucarelli, beta thalassemia can be stratified into 3 risk classes according to the presence or absence of hepatomegaly, portal fibrosis, and history of inadequate chelation, where risk class 1 contains no risk factor, risk class 2 contains 1 to 2 risk factors, and risk class 3 contains the 3 risk factors. As you can see here, 17% of our patients were belonging to risk class 1, again 15% were belonging to risk class 3, and the majority of patients were belonging to risk class 2, constituting almost 68% of our patients. Regarding the stem cell source, and this is quite related to the size of the donor, 132 patients received stem cell from the peripheral blood, while 20 patients received stem cells from the bone marrow. The stem cell dose regarding the peripheral blood group, they got a mean C34 count of 13.6 by 10 to the power 6 per kilogram body weight of the recipient. Again, in the bone marrow, they got a mean of 6 by 10 to the power 8 total nucleated cells per kilogram body weight of the recipient. This is the conditioning regimens we are using, and we try to cut down the expenses. Our classical conditioning regimen we started and continuing on is the BU-Cy ATG regimen, while 10 patients received flu-BU-Cy ATG and another 5 received flu-BU-Cy regimen. HCV was proved to be positive in 20% of the patients, while 80% were HCV antibody and PCR negative. Again, out of the 152 patients, 69 patients had a serum ferritin below 2,000, and 83 patients had a serum ferritin of above 2,000. This is our main conditioning regimen. Again, we are using the Busulfan between 16 to 20 milligrams per kilogram body weight orally over 4 days. Then short course cyclophosphamide 120 milligrams per kilogram body weight over 2 days, and then ATG 110 milligrams per kilogram over 11 days. And the rationale behind using this conditioning regimen was we are getting a higher Busulfan dose for children under the age of 6 to meet the same pharmacokinetics like that in the older age. Again, we are adopting a short course cyclophosphamide, trying to decrease the incidence of cardiac and hepatic toxicity, and ATG was used for more immune suppression and to compensate for the less dose of cyclophosphamide, again for in vivo purging of the one log higher T cell content in the graft, trying to reduce the incidence of acute and chronic graft versus host disease. Regarding the engraftment, regarding the neutrophil engraftment, the mean days for neutrophil engraftment was 21 days, while the mean days for platelet engraftment was 52 days. Documentation of primary was done by DNTR, and for those who are having a sex mismatched transplant, karyotyping was done. We used to do it on a monthly basis for the first 6 months, then at the end of the first and second year. This is regarding our results. Almost 70 patients had a complete chimera, 20 patients had a stable mixed chimera, and 11.2% had rejection. 1 had a primary graft failure, while 16 patients had a secondary graft failure. Again, this is our incidence of GVHD. 23 patients had an acute GVHD of an incidence of 15%, and chronic GVHD of around 10%, while transplant-related mortality that are related to the veno-occlusive disease was 4 out of 152 patients, and 2 patients died out of graft failure. This is again the incidence of acute GVHD. As I said, 23 patients had an acute GVHD, 16 patients had chronic GVHD, and this is the transplant-related mortality. It's a bit significantly high, 17.7%, and the main reasons were veno-occlusive disease and infection. Again, as I said, infection, DOD, and acute GVHD were the most common transplant-related mortality causes in our cohort of patients. Regarding our overall survival and disease-free survival, and again, these are very clean and updated data, and with a median overall survival of more than 10 years now. So our overall survival was almost 83%, and our disease-free survival was 72.4%. When we talk about overall survival in relation to the stem cell source, you can see that we're having an 80% overall survival in the bone marrow group, and 82.5% in the peripheral blood. And if you look to the disease-free survival, it's 64% for the bone marrow and 74% for the peripheral blood. And when we talk about overall survival and disease-free survival in relation to the conditioning regimen, our classic conditioning regimen had an overall survival of 84% and a disease-free survival of 75% for the whole group, while those who received good USI and good USI ATG had a much worse outcome. When we try to see other prognostic factors that can be correlated to the outcome, you can see here that those who had a seroferrin of less than 2,000 had an overall survival of almost 90% and a disease-free survival of 81%, while those who are having a seroferrin above 2,000 are having an overall survival of 75% and a disease-free survival of 65%. When we looked into the HCV status before the transplant, there was no significant difference whatsoever between HCV positive and HCV negative patients. They are almost having the same overall and disease-free survival. Again, when we looked into the outcome in proportion or in relation to the risk classes, you could see that risk class 1 is having a much better overall survival and disease-free survival in relation to class 2 or class 3 disease. This is again our overall survival of 83% for the whole group. and our disease-free survival of almost 73% for the whole group. And this is our disease-free survival, and for the bone marrow and the peripheral blood, there is a significant difference, but it did not reach statistical significance. Again, when we talk about disease-free survival for those who are having a low serum ferritin in proportion in relation to those who are having a high serum ferritin, you could see that there is a statistically significant difference between both groups. This is HCV positive and HCV negative patients, almost an overlapping curve. There's no differences whatsoever. And lastly, this is our disease-free survival in relation to the conditioning, where the USI-ATG is having a disease-free survival of 75%, and as I said, those who receive flu Psi and flu Psi ATG are having a much worse outcome. Lastly, the risk classes, where risk class 1 is having a disease-free survival of 85%, while a disease-free survival for risk class 2 and 3 are around 70 and 65%. Coming to this slide, I would like to give you a take-home message from my presentation. The USI-ATG regimen, at least in our experience, is still the golden standard. HCV did not have any impact on outcome. Again, higher serum ferritin was coupled with an inferior disease-free survival, and so one should try to aggressively delay patients before putting them into a transplant. Lastly, bone marrow was associated with a higher graft rejection rate. And coming to here, I would like to thank you for your attention.
Thank you very much, Professor Haddad, for this very comprehensive and elaborate book about human transplantation in Egypt. Our next speaker is Dr. Uriu Ibepi, Program Specialist, Social and Human Sciences in Cairo office. The talk will be ethical and legal issues of human stem cell research. From the human embryo and adult stem cells like bone marrow or the blood stem cells and induced pluripotent stem cells. So I think a major issue here in this conference is adult stem cells. But however, and then also the ethical question of the adult stem cells and the embryonic stem cells is quite different. So when we're talking about the ethical question, it is more close to the embryonic stem cell research. Then what is the relevance of the embryonic stem cell research for the thalassemia? So I just quickly Googled and I found some scientific papers or the research done for the beta thalassemia using the gene therapy or the embryonic stem cells, and also the induced pluripotent stem cells. So I think it will be interesting to know also for the thalassemia therapy, the relevance for the ethical question of using stem cells, the embryonic stem cells and the induced pluripotent stem cells. So So what is the ethical question of the embryonic stem cells? The ethical question is basically what is the moral status of a human embryo? Is it allowed to use a human embryo for research or not? And if it is allowed, how to obtain the human embryos? Is it allowed to receive a donation or create embryos for research purposes? And how about to manipulate the genes? It will be also related to gene therapy, but the genetic manipulation of the human embryo, is it allowed or not? And then what is the ethics of therapeutic cloning, which is to create the embryo by somatic cell nuclear transfer. And then also the general issues like intellectual property rights and benefit sharing. So what is the moral status of human embryo? This is the most difficult question to understand. Is it a life or thing? If it was a life from the beginning of the moment, or it becomes life from a thing. If it is a case when it will become a life. So there's a certain criteria discussed in the bioethics. Is religious perspective. When is the moment of ensoulment? When the embryo receives the soul, then it becomes a human life. Or we can distinguish the different stages by the developmental stage. At certain level, the human embryo becomes a one integrated entity that is not divided into the twins or the other class of the cells anymore. So that is the criteria called the primitive streak. Primitive streak appears on the human embryos around 14 days. Then that is an integrated entity and it should be protected. That is the one criteria. And then another argument is that there is a potentiality to life. So the potential or the probability to become alive will develop, increase by the developmental stage of human embryo. So it is not a certain point which changes the moral status of embryo, but gradually it becomes more and more obtains a right to life. So the later stage of the fetus has more right than the early stage of human embryo. That is one way of thinking. And then the classical way of thinking when the life starts is that it is employed in the abortion debate, that the viability of the fetus. So if the fetus can survive outside of the womb, that will be claimed as a life and it needs to be protected. So when we're talking about human embryos, what is the sources and what's the ethical problems, ethical questions related to the different sources of the embryos? How about the the cloned embryo? Cloned embryo does not go through the fertilization of the egg and sperm, but it is using the somatic cell nuclear transfer. So there's no fertilization. Is it the same category of human embryo or not? And then there's another question, the supernumerary human embryos. So that if the embryo is created by the fertility treatment for the purpose of making a baby, but it is left over, it is supernumerary, so you don't need it anymore. Is it good to use it for the research or not? Or there is a human embryo which is from the beginning created for the purpose of the research. So the human embryo created for the fertility treatment and then left over. And the human embryo created from the beginning for the research purposes. Does it, the intention, the purpose of the creation of the embryo, does it to make a difference for the moral status or the importance, value of the human embryos or not? And strangely, it is, according to the current regulations. As a UNESCO, we have worked several reports and documents about the ethics of human embryo research. And then according to that, we also made a worldwide survey. What is the regulation in the countries in the whole world? So there are some countries that permit the research on human embryos. They are more likely to permit the research on embryos who are left over from the fertility treatment. But they consider, some countries prohibit creation of the human embryo for research purposes. So they consider that is another step further. So that means, so something left over, it can be thrown away in the bin, so why don't you use it in the research? But create the embryo, make a fertilization for the research purpose, can be something, maybe the violation of human dignity, human life. That is a kind of the, how to say, the feeling or the kind of understanding in this resolution. So when we see the UNESCO has an international biases committees. When we discussed and we made a report about the ethical question and the use of embryonic stem cell research, we found that there is no, worldwide agreement or the uniform consensus can be reached because there's already different legislation adopted in the different countries. But it should be agreed that the basic principle, the protection of human rights and human dignity, should be respected in any means. So the interpretation of the concept of the human life must be different in each country, but in each country should make a debate and make a guideline how to protect the human dignity. We have some publication on this. So I just want to give you an example how the work in the international community, the United Nations member states consider the human embryo, moral status of human embryo, and when the life begins. And actually, we did not reach this consensus. There was a United Nations Declaration on the Human Cloning adopted in 2005 by the member states, all member states of the United Nations. But actually, they started this discussion from 2001. And in the beginning, they wanted to make a convention to prohibit human reproductive cloning. They thought it is a very easy job to adopt the human reproductive cloning to be prohibited from all over the world. Because they couldn't imagine there's any country who will go for the reproductive cloning, to make a clone human being. So they thought it would be very easy to make this convention. But actually it was not. Because this is the problem was that some member states, actually the United States and the Roman Catholic countries, they refused to make a distinction, the different moral state, a distinction between the therapeutic cloning and reproductive cloning. For them, all human embryos are the same, either created by fertilization or somatic cell nuclear transfer, and there should not be any different purpose for the research or the reproduction. So they refused to just discuss about the prohibition of human reproductive cloning, but they wanted to include all prohibition about the creation of the human embryo for research purposes through the fertilization or somatic cell nuclear transfer. But some other countries have already the regulation to allow the research on human embryos. So of course we could not reach the consensus, so at the end we began the declaration stating that member states are called upon to prohibit all forms of human cloning in as much as they are incompatible with human dignity and the protection of human life. But in this declaration, there is no definition of human life. What is human life? It doesn't say if the human embryo is human life or not. They just state the cloning, the human cloning, which is violates the human life, should be prohibited. So after the adoption of the declaration, the UK, Netherlands, Belgium, some member states who allow the research on human embryo already, they said, okay, the human embryo is not a human life. So even if we adopt this declaration, it does not prevent them to conduct the research on the human embryos. And some other countries, conservative countries, on this issue, like Costa Rica, Germany, Ireland, say, okay, we adopt this declaration. That means human embryo, they consider human embryo is a human life. So this declaration means the prohibition of the research on human embryos. So when we see the position of the Arab states, it's really interesting. So in favor, so the member states will adopt it in favor of this declaration. It means they can be more, prohibitive position to conduct the research on human embryos or creation of human embryos for research purposes, because it does not give them definition of human life, but just give the prohibition. So it can be interpreted that the human life, the human embryo should not be destructed. So when we look at the Arab states, the Bahrain, Kuwait, Iraq, Morocco, Qatar, Saudi Arabia, Sudan, United Arab Emirates, they have voted in favor. That means that they are more agreeing prohibiting the research on human embryos. And there is no the Arab member states voted against. So against means they are more favored to do the research on human embryos. But only the other countries like Algeria, Egypt, Jordan, Lebanon, Oman, Syria, Tunisia, Yemen, they are just abstaining. So when I go closer into the position and thinking of the Arab member states, we had an expert meeting on legal and ethical issues of human embryo research in the Arab states. So discussion and the findings of this meeting is that according to Islam, it's quite a bit contradictory from the UN Declaration of World that according to Quran, it is not, we can see that the human embryo is not a human life, and research on human embryos can be permitted. Because in Quran, they say that there is a 3 stages of the creation of the man. It is created from the items of the utensils of clay, and then become the nutfa, equivalent to semen, or the mixture of the zygote, mixture of the ovary and sperm, so like an embryo. And then become the alaka, it's like a blood-like or the leech-like blood clot. And then become mudga. So, and Quran does not mention how long each stage will take, but according to Hadith, that each stage will take like 40 days. And after that, so that means after 120 days, the ensoulment will happen. Angel is sent, and then the soul will be breathed into this embryo. So this is the majority. There's also the other school thinking that the ensoulment will happen at the day of after 40 days of the conception. But based on this understanding, actually the Islamic teaching is much more flexible or permissive to the human embryo research than Christian thinking. And for this meeting, we had another findings. So if we permit the research on human embryos, what is the source of the human embryos for research purposes? There are 2 different opinions about the resource. So some think that the creation of human embryos with donated sperm is a kind of disturbing, because in the Islamic countries, according to Quran, the creation or the creation, the reproduction should be within the legally married couples. So if you take the sperms and over with not related, not married couples, that will may give the potential of illegitimate embryos for the children. So it should be prevented So that even for the donations for the creation, the research for embryo, it should be donated to the legally married couple. That is one way of thinking. Another way of thinking is, but if the couple donates the human embryos, they will contain the same genetic component. So that might be psychologically disturbing because this can be the same genetic the lineage with the siblings. So it may be better to have the unrelated donations and create the research embryos purely for the research purposes. Because they are not married, the gamete will not come from the married couples, so there is no place to go back. So there is no chance for this embryo that somebody claimed for this embryo as their children. There is no place to go back. So it is more clear that it can be used only for the research. That was a quite interesting argument, which is very peculiar for actually based on Islamic thinking. So when we go a little bit more closer into each country's regulations, we conducted a survey, UNESCO conducted a survey in 17 selected Arab countries for, this is a documentation. We have the outcome of the survey, and we surveyed 10 issues. The regulations, national regulations on human reproductive therapeutic cloning, embryonic stem cell research, genetic tests, and organ transplant, like this. So according to this survey, most of the countries, they do not have tackled yet to the regulation on research on human embryos or embryonic stem cell research, human cloning, even the regulation of the artificial assisted reproductive technologies. But only very few countries have some regulations. For example, in Egypt, the preservation of embryo and research on leftover human embryos are permissible by the decree of the Ministry of Health. And Algeria is a little bit prohibitive. Research on human embryo only for the sake of the human, the embryo itself is permitted. That means that the destruction of the embryo is not allowed. And Tunisia is clearly prohibits the creation of the embryo for research or prohibits the import of stem cell research. And Saudi Arabia is also prohibited create embryos for research and prohibit import and export of the stem cells, except having the authorization from the committee. And Morocco and Palestine, they do not have a clear guidelines, so they have kind of organ donation law, abortion law, is analogies, and they have a prohibitive position. In Qatar, there is no possibility to have a human embryo research because the creation and preservation of human embryo is only for the reproductive purposes. So it is quite interesting because Islamic law can be permissive for the human embryo stem cell research, but the actual regulation in the countries is a very much prohibitive positions, and many countries do not have regulations. That is because I think there is no need yet for the technicality, urgency to establish the guidelines. So the findings of this expert meeting was that along the development of this immunology and scientific research, that the regulation should be revisited in the countries. So for the moment, only the Jordan has been discussing to establish the guideline, the national law, actually the draft law, to regulate the stem cell research in general, including the establishment of the data banks and also the embryonic stem cell research. So then the Jordan can be the first country to permit the embryonic stem cell research by law. But it is still under the process, and it will be quite long that we're discussing it. So now I will talk very briefly about adult stem cells, bone marrow, umbilical cord, ethical problem of this research. So actually, there is a lot of countries in the Arab states, like Egypt, Lebanon, Jordan, and United Arab Emirates, they have been establishing the biobanks of the umbilical cord blood, but many of them do not have the proper regulation yet. Some are starting the private biobanks, which is branches, become the branches of the foreign-based companies. So how to keep this the data, the samples, and how to obtain the informed consent. So that can be needed to be discussed. So finally, the induced pluripotent stem cells. Induced pluripotent stem cells is quite recent discovery, and everybody thought. So now that we don't have to discuss about ethical problems of human embryos anymore, because induced pluripotent cells is produced from the somatic cell, which has not much ethical question of using stem cells. But they, using the different types of the genes, they succeeded to make it as if it functions like embryonic stem cells. So they obtain the pluripotency from the stem cells. However, it does not, waive away the ethical question of embryonic stem cells, because it will give a new set of difficult questions. Now, before, embryonic stem cells and adult stem cells has a clear division. Adult stem cells will never produce a reproductive cells. But the induced pluripotent cells is made from the somatic cells and can produce the gamete itself. So that means that you take out any cell from your body and you can probably maybe produce a baby in the future. So then it will go back to the same question of the question of the human embryonic stem cells. So that is just giving us an example of the ethical issues of input in induced pluripotent stem cells, and this is the end of my presentation. Thank you.
Thank you very much for your very elegant presentation. Now we open the floor for discussion. Join us on the podium. Would you join us on the podium, please? The two speakers. Any question on the floor? Yes, please.
السلام عليكم. محمد سحان, professor of pediatrics, Mansour University. I asked both because the forums and Dr. Ala about the bone marrow transplantation. Let's say how many cases per year are diagnosed as newly diagnosed beta thalassemia major, and how many cases can we select for bone marrow transplantation, eligible for bone marrow transplantation, and we must do it like how many cases are selected compared to the conventional therapy, the long-term blood transfusion and chelation therapy. So we can calculate the cost. And I think this day is a thalassemia day. We must have a consensus, and we must have a clear message for everybody interested in thalassemia worldwide, especially in our area. So, how many cases can we get benefit of bone marrow transplantation really in our world, and what are the percentage of these cases to the already present thalassemia cases and the newly diagnosed every day, and what is the cost in our country compared to bone marrow transplantation? For example, we don't calculate the cost of admission in hospitals, blood transfusion, just we have to pay for chelation therapy. In other modern or high socio-economic standard world, they calculate the admission, calculate the cost of the blood unit. So you said the cost of conventional therapy, the bone marrow therapy, is more than the bone marrow transplantation. Is it applied really in our country here? Thank you.
Okay, I will answer the cost issue. Okay, so I think on the cost issue, the situation is very clear. In Thailand, you know, the Cairo rate is probably 30%. Actually, thalassemia apparently is 1% of the Thailand population that has thalassemia. And they have looked into cost effectiveness very carefully. Even a few years ago, when chelation therapy was not as expensive as it is now, and life expectancy was probably less than that. So, and they have, the conclusion was that definitely in children that have a compatible donor and that are low risk. Now, that is a matter of definition, but I would say that most children less than 7-year-old without a big liver can do very well with bone marrow transplantation, and bone marrow transplantation can be very effective, also in terms of costs. And that is increasingly so because chelation therapy, supportive treatment, is becoming more and more expensive and is becoming for longer and longer years. So there is no question on that. I think now we will see what the professor has to say.
I cannot agree more. Actually, we have transplanters, so we have a little bit bias. We are not taking into consideration.
Overall, change in management is benefits happening in 90%. Potential benefit of using FDT as diagnostic for management tool, and furthermore, these data should provide useful to assess the cost effectiveness of using FDT management of patients with cancer. And this is my recommendation for prevention of colorectal cancer, fruits, and vegetables.
يبقى الكواليتي اوف ايفيدنس ده مهمه. ريتنج سكيل، حد قالها في وسط الكلام ان انا ممكن احط، يعني اقول مثلا لو جاب كذا